Hello. Good evening, everyone. Respected Dr. Rohit Agrawal, sir, esteemed members of the International Association for Dental Practice Excellence, and my dear colleagues. It gives me immense pleasure to welcome you all to yet another episode of Learn from Our Master series organized by the IATPE. Crossing more than 75 successful webinars has truly been an amazing journey for us. On behalf of IATP, I sincerely thank all doctors who continuously support us by attending our webinars and by actively engaging with us on our Instagram, Facebook, and other academic platforms. Your encouragement and positive feedback motivate us to keep moving forward. For those who are attending an IATP webinar for the first time today, I briefly introduction about us. We are the International Association for Dental Practice Excellence, an academic dental platform that strongly believes quality education always ensures predictable clinical outcomes for dentists across all disciplines and level of experience. Dentistry is a complex and ever-evolving field, and continuously learning is essential. With this vision, we conduct regular webinars and workshops to enhance clinical skills and guide dentists throughout their professional journey. Coming to today's session, we are privileged to present a webinar on topic Tilted Implantology, a revolutionizing technique. It is my honor to introduce today's speaker, Dr. Rohit Agrawal, MDS, with over 15 years of clinical and academic experience. Dr. Rohit Agrawal is a highly respected name in the field of dental implantology. He has been at the forefront of advancing dental care in central India, excelling both as a clinician and as an educator. Without taking much more time, I would like to invite Dr. Rohit Agrawal, sir, to take over today's discussion. Welcome, sir.
Yeah, good evening. And thank you for inviting me. And a very happy new year to everybody. So, we will directly start the session so that uh, we have a good, knowledgeable session. And please put up your queries. If you have any queries, please put up your queries. We'll have a Q&A session in the end. And it is going to be completely clinically oriented session. So, no boring stuff. Okay, just a second. I'll just start the session. So, I'll be talking about the tilted implantology. See, we all want to do tilted implantology, but basically you have to understand this point. Tilted implantology, what I believe in it is that it is not a replacement for your axial implantology. Don't take it like that ki we have to tilt in every case. Like it has to be done when it is required, not because you know it, so you have to do it. Like for example, if today I learn about zygomatic implants, so tomorrow morning it should not be in my mind that every patient I'll keep on doing zygomatic implants. So that is how you should learn about any new technique. That it is indicated for a particular case, not for every case. That is the basic thing I want to convey before starting my session. So it is not something like that. Even if you have sufficient bone, you start tilting your implants. Means you have sufficient bone for all in six, but still you're doing all in four. Just because you have done a session or you have undergone some kind of a training. So don't do that way. Okay. Your axial implantology is always gold standard, followed by MISH. You have lot of studies, articles, research, and data. It is good. But now as the times are progressing, so we all are seeing cases in which patient does not want to go major surgeries, no grafting, they want immediate results. So because of all those things, now we have a good technique which is called the tilted technology. So with which we can give immediate results to the patients, and it has sufficiently long-term data to suggest that the prognosis of the prosthesis is very good. Okay. So straight away I'll start. So this is like you are seeing this case. It is a patient who is missing lot of maxillary teeth. So this is the OPG of the patient. So as you can see here, you have multiple missing teeth. We are planning to replace the teeth from this first quadrant, means from the upper right, second lateral, from the lateral incisor 1, 2, up till the first molar in the second arch. Okay. So as you can see, there is a sinus lining here. You can see sinus lining here. Okay. Uh, Yeah, sorry for the disturbance. So if you tried, like if you want to place straight implants here, you have to go for sinus lift in this region. So instead of that, we opted for tilting the implants. Before tilting the implants, see, I told you before also, if you have seen my cases, or seen me in any other platform, implantology is all about prosthetically driven. It is not surgically driven. That first you place the implant, then you start scratching your head that what I will do now, and you call up the technician or other dentist and ask, sir, ab kya karna hai? What we want to do now? No, that is a wrong way of doing implantology. It is more about planning the case rather than executing the case. So if you plan well, you will have good results. Okay, and you will not have nightmares. So that is how it goes. So before starting the implantology, let us first understand, if you are tilting any implant, what is the basic requirement of the prosthetic part. So basically, if you want to tilt any implant, first of all, you will require multi-unit abutments. Okay. No matter which system you are using, they all have multi-unit abutments, because multi-unit abutment is the only abutment which allows you to correct the angulation of the tilted implant, because you want your path of insertion and removal parallel. So if your implants are tilted like this, with the help of multi-unit abutment, whether it is 30-degree or 45-degree, you can correct the angulation of your processes. So path of insertion and removal will become parallel. So like for example, I'm showing a multi-unit abutment here. Every company has some design, but basically they look like this only. This is a multi-unit abutment. It is called multi-unit abutment because it has kind of two units. One unit, as you can see here, this goes inside the implant surface, inside the internal surface of the implant, and this unit which goes inside the prosthesis. Any type of processes, whether you're doing a PFM, DMLS, or you're doing a zirconia, or you are doing any bar based hybrid processes, irrespective of that, this part of this abutment will go inside the prosthesis, and this part will go inside the implant. So it has two parts. That is why it is called multi-unit abutment, and it comes with two screws. It has two screws. One screw will go inside the implant, and another screw will go inside the prosthesis. Okay, that is the basic gist of the story about the multi-unit abutment. You have different angulation, as you can see, 17-degree, 30-degree. You have different collar height. This collar height you can decide based upon based on the basis of your vertical soft tissue thickness. How much is your vertical soft tissue thickness? Based upon that, you can choose your this thing collar height. Okay, forget this angulation and all those, this angulation of the this circular thing, that is not important, that is fixed by the company. Mainly thing is that you have to understand this angulation, whether you want a 17-degree multi-unit abutment or 30-degree multi-unit abutment, based on the angulation of your implant. Okay, like this is a straight multi-unit abutment, and this is your 45-degree multi-unit abutment. So in the end, your final process's path of insertion and removable will become parallel, and it will be screw retained processes. With multi-unit abutment, thing is that you can only give screw retained processes. You cannot give a semen retained processes on multi-unit abutment, which is obviously a good thing. We do not want semen retained processes. As you all know, excess semen can lead to periimplantitis. Secondly, any type of processes you are doing, especially if you are doing full arch cases, one of the main criteria for a successful processes is that it should be retrievable. matlab in future you can remove it, because if you want to do some kind of a follow up, patient comes back to you after 6 months or 1 year and you want to clean everything, there is some kind of ceramic chipping, so you can easily take out the prosthesis, send it to the lab, they can do the cleaning and everything, they can do the repair work and you can place it back. So that is the beauty of using the multi-unit abutment. Okay. So what I have felt over these years and what I have discussed with many dentists is that they are very much like in kind of a situation or dilemma that they are afraid of multi-unit abutment. I don't know why. It is not something very to be scared of. Multi-unit abutment comes with every system. Okay, you have to keep one extra set of prosthetic parts. That is the only thing. But it is very easy to use. It does not complicate your life. It simplifies your life. Okay. So using multi-unit abutments will simplify your life, not complicate it. Secondly, if you are doing tilted implants, you have to use multi-unit abutment. You do not have a choice in that. Okay. So that is how it goes. So like in this case, these are long implants. We have done the tilting of this implant. This is of 5 mm diameter and we have engaged the lateral wall of the sinus lining. You can see here we have engaged the lateral wall of the sinus lining. So we are engaged this cortex also, this cortex also. This is a tilted implant. So here we have to use the multi-unit abutment of 15-degree angulation. So now after taking the impression, we are doing the jig trial. Whenever you take the impression, whether you're doing single implants or whether you're doing two implants or whether you're doing partial arches or whether you're doing full arches, you are supposed to do jig trial, because jig trial will verify the accuracy of your impression. Hence, then only your final prosthesis will be passive. Understand this point. Passivity of prosthesis, whether single implant or multiple implants, is very important. Every prosthesis, whether cement retained or screw retained, has to be passive. That is the golden rule about implantology. So we are doing the jig trial. If you can see here, this is the jig which has come from the lab, which is this is the pattern resin, this is your impression copings, and we can seat it inside patient oral cavity, and you can check it with your naked eyes that all the impression copings are seating properly. That means your impression was accurate. Okay. Similarly, if you are doing a cement retained prosthesis, which is an implant level prosthesis, okay, see, this is your abutment level prosthesis. Your implant is deep inside the soft tissue, so it is safe inside. With implant level prosthesis, like you do normally your cement retained prosthesis, what you do, you have to remove the healing abutment again and again. So what you are doing in that process is that you are breaking the hemidesmosomal attachment, which is the peripheral tissue seal, which can also lead to crestal bone loss in the long run. Okay. Plus, it causes lot of discomfort to the patient. You might have noticed that you have removed the healing abutment, and if you pass by, like if you have taken around 2 to 3 minutes, and if you try placing the healing abutment, sometimes patient starts saying, "Sir, it is paining again," and you have to give the infiltration. And sometimes the patient says, "Sir, how many times you will give me infiltration?" Because you have to take impression, then you have to do jet trial, then you might have to do BIS trial also, metal trial also. The patient becomes fed up. He says, "Sir, how many times you will keep on giving LA?" That too, that case I'm talking about single implant. Now understand you are doing multiple implant. Supposedly you have removed the healing abutment here. By the time you will remove the healing abutment of this implant, this tissue would have shrunken down. So if you place the impression coping, patient will complain of pain. With multi-unit abutment, that is not the issue, because the prosthetic platform you have shifted from the implant level to the tissue level. So it is above the tissue now. So now what happens is that whenever you're working on this patient will not have any kind of pain. And everything you can see with the naked eyes. I don't have to take the X-ray also. So my life becomes easier. Patient is also comfortable. You don't have to give infiltration. There is no bleeding. So all becomes very good. It is easier to maintain also in long run, hygiene wise, easier to remove. You can remove it, it is screw retained. So everything becomes lovey-dovey. Okay, that is the story. So this is now I'm doing a metal trial. So this now we are doing the metal trial, as you can see. So everything you can see with your naked eye. There's no need of taking any OPG also, because everything is neat and clean in front of your own eyes. So this is the OPG with the metal trial. You can see everything is sitting perfectly. This is the BIS trial. You have 5 implants here. Okay. 5 implants we have placed. Palatal placement. I always told you all, whenever you're replacing your maxillary teeth from first premolar to first premolar on the bilateral side, all your implants should be palatal. Okay, that is the basic rule about implantology. So this is palatal implant placement, screw retained. This is a DMLS prosthesis. Now we are doing a BIS trial to check for the occlusion. Any occlusal discrepancy is there, you can reduce it. So on the day of prosthesis, you have to just pick it up from the cast and place it inside the patient's oral cavity. You don't have to pick up your erotor at all. Okay, this is a BIS trial. This is the final smile of the patient. This is on the day of process delivery, and luckily it was his 70th birthday. So in the morning only patient told me, sir, you have given the best gift to my uh, of my life. It was something like that. Actually, I was not knowing it was his birthday, but luckily it was his birthday. So this is the final OPG of the patient. Everything is screw retained. Plus, second advantage of tilting is that with tilting, what you can do, you can place longer implants. Supposedly in straight way, I am able to place 10 implant. But if I tilt it, I can obviously place 12 or even 13 of implant. So by increasing the length, what you are doing, you are increasing the BIC. BIC meaning bone to implant contact area. Hence, we are getting more amount of surface area of the implant, which is getting osseointegration. So obviously we will have a long-term better prognosis. So that is also one of the added advantage of doing tilted implantology. You can also increase the length, hence thereby increasing the BIC of the implant. So now this case is there. So now this is little bit complicated case. If you look at here, it looks like this implant has gone completely inside the sinus. No, this is a palatonasal implant. What you do here is that I will not advise this technique to everybody. Okay, but okay, first let me discuss about this. This is a palatonasal implant, 3.75 by 16 implant is this, and you are placing on the palatal bone and then engaging the nasal cortex on top of it. So buccally, when you take the X-ray, it looks like it is inside the sinus. Actually, it is behind the sinus on the palatal wall, engaging your nasal cortex. So it is something like that. Okay. And in this case, we have done the indirect sinus lift with Nova bone putty, and this is your straight implant. Okay. So this is the we have taken a digital scan. You can see it is like kind of a tilted implant. You can see it is coming buccally. Okay. So here, because the tilt was not so much, so we were able to use normal cement retained abutment. This is a customized cement retained abutment. This is a normal abutment. This is again a PFM, and this is the final IOPA. Passive fit, cement retained. You can see this is the posterior two implants. This is the front implants. Okay. Platform switching is there. You can appreciate the platform switching also over here. Okay. Now this case is there. Again, a full arch case. So this is the CBCT of this patient. You can see here, this is the CBCT of this patient. Okay, so it is kind of a all-in-4 kind of a case where we added one more extra implant. Okay, so this is the implant, anterior implant. These are a tilted implant. Normally, if you are doing a case of extraction, like if you are doing the case of extraction, so what happens is then when you extract these teeth, you will get ups and downs in the bone. It is like a valley. It has some elevations, then depression, elevation and depression. So don't directly place implants. First, do horizontal crestotomy and make the platform horizontal. Again, this is a prosthetic planning, because what happens is that if you leave the platform like this, elevation and depression, so in the final prosthesis, when the technician will design a prosthesis, the intaglio surface, he won't be able to give a intaglio surface which is convex, because you left the elevation inside the bone. So obviously it will create a depression inside your intaglio surfaces of the prosthesis, which will lead to food lodgement in the long term. So keep that point in mind. Whenever you're doing a full arch case, especially extraction cases, so make the platform horizontal. Okay, that point is very important. Okay, one of the advantage, another advantage of doing a horizontal crastotomy is that as your platform becomes flat, it is easier to drill. It is easier to drill with the pilot drill. Sometimes what happen, if you have a knife edge ridge, if you try to drill, your drill will wobble. But if you flatten it little bit, because the bone in the lower region, what happens is that it is something like this. It is in the shape of like this. As the bone go, if you go in a apical region, the bone widens. So if you flatten this tip of the knife edge ridge, it becomes like this. So it is easier to engage. Like you can see here, now it is easier to for me to engage. Okay, and try to place your implants inside interradicular bone here. Supposedly, if you place your implant here, somewhere here, so it will be completely covered by the native bone all around. Okay, so you can see this implant is tilted. This implant here is tilted. You can, if you look closely, you can see this is the mental nerve. Okay, if you are doing a full arch case, mandibular full arch case, and it is not a guided surgery, freehand, so you have to expose your mental foramen. You have to visualize your mental nerve with your own naked eyes. Then you should tilt your implant, making sure the tip of the implant is at least 5 mm ahead of your mental foramen, because we know it takes a curvature in the frontal aspect of your mental foramen, which is around 3 mm, and 2 mm is for the safety. Okay, you can make your markings with the pencil also, that is also acceptable. Okay, so now this is the healing stage. You can see these are a multi-unit abutment. Now it is a tissue level prosthesis. You have transferred the implant platform from the implant level. Now we are working on the tissue level. So it is very easy for me to work here. Implant is safe inside the bone. I'm not again and again opening my abutments like you do in your implant level prosthesis, where you have to remove your healing abutments again and again. So you are breaking that tissue seal, which does not happen here. That is like it is following the one abutment, one time concept. Okay, it is also called one abutment, one time concept, where you do not open the abutments again and again. So it is very easier to work for me. Patient is also very comfortable and everything happens smoothly. Okay. So again, if you are taking a open tray impression manually, you are supposed to place your open tray impression coping and splint them with the help of a pattern resin. Okay. You have to splint them with the help of a pattern resin, because pattern resin tends to have least amount of shrinkage. Okay. So this is your impression. You have taken a putty wash impression. This is light body. This is your addition silicone. You can use polyether also. So after you have taken the impression, always check for the stability of your impression coping. This is your lab analogs. Always check for the stability. If they are mobile, no need of pouring the impression. Redo the impression. Okay. No need of going ahead only. See, like if I share this video, I'm checking the, see, this one is mobile. So there is no need of going ahead with the pouring the cast also. Repeat the impression. This is stable, this is stable. Only finger touch you have to do. Don't make it like this, otherwise it will move. Okay. But you can see with feather touch also, finger touch also, it is moving. So you have to repeat the impression. That goes for any type of processes, whether you're doing full arch or partial arches. Okay. So this is the cast. Now you get the jig trial. Okay. So now we are doing the metal trial. So this is on the cast. Same way, everything should seat inside patient's oral cavity passively. Okay, I told you passivity is very important. But now, if you can see here, Madhya Pradesh, here we are doing this one screw test. I've got this metal trying for this patient. We are giving a fixed PFM prosthesis for the lower pedunculus region. Okay, so as you can see, this is a metal trying. I've placed it on this multi-unit abutment. So you can see now it is seating perfectly on all the abutments. Okay, this is, I have not placed the screw yet. Okay, so that means it is passive fit. There is no gap anywhere. See on the, we can see on the lingual side also. lingual side also we can see. So I have not placed the screw also. So that confirms my passivity. So on the cast, if it is seating properly, that means the lab has done the proper job. Now, if you pick it up from the cast and it is not seating inside the oral cavity, so it is your fault, not the technician's fault. That means there was some error in the impression. Means there was some mobility, the position of the final lab analog in the cast shifted, hence the prosthesis was not passive. That is why I always insisted that always do jig trial, because these are screw retained prostheses. So you cannot have 1% error also, because otherwise if your prosthesis is not passive, you have done tightening of the screw by force, means your occlusal forces will be transferred to the screw. So you will have prosthetic complications in long run, like a screw fracture and all those things. Worst case scenario, it can lead to abutment fracture also. So that you have to keep it in mind. So this is your final prosthesis, DMLS. This is kind of a FP1 prosthesis. So this is the final OPG of the patient. Okay, tilt. We were able to place one more implant, so we place one more implant. No harm. Okay. So this is, I think so, after 3 or 4 years, patient came back. He said, "Sir, doc, I want to get these two teeth also done." Initially, he was not ready. So we placed two more implants. Then he did not turn up. It's been more than 6, 7 years now, I think so. So this is the follow-up of this patient. I think so. This is after 4, 5 years. There was some amount of calculus deposit, but everything else was fine. Everything else was fine. This is the follow-up actually. Okay. So bone level are also good enough. So this is a good case. So again, now one more full mouth case. So you can see this is kind of a tilting. You see, tilting has been done. Like this is, you can see both type of cases in this OPG. Tilting also and normal axial implants. When I had sufficient amount of bone, why to tilt? Why to tilt? Okay, place your normal parallel axial implants. Okay, here because I had to go for bilateral sinus lift, that's why I've done tilting of these two implants. These are both 5 mm diameter implants. Okay, and two straight implants, all in four. So you have placed multi-unit abutment to correct the angulation. Again, 45-degree multi-unit abutment, and these are a straight multi-unit abutment. Okay, and this is your implant level processes. So you can see both type of processes here. One is tilting, one is straight implants. This is abutment level processes. This is implant level processes. You have to remove the sealing abutment again and again. You will keep on breaking your peripheral tissue seal, and patient might also have discomfort because first you will remove this sealing abutment. By the time you will remove this sealing abutment, there will be tissue shrinkage here. So that also complicates your life. Plus you have to take multiple IOPAs or OPG also to confirm the seating of your prosthetic parts. So impression, like you any day take putty wash impression with light body, and this is at the jig. After you have taken the impression, jig for sent by the lab. You can see the jig has been sent from the lab. Now you will pick it up same like this from the cast, and it should seat like this only inside oral cavity. Along with this attachment on the top, everything should seat like this only. That confirms your impression was perfect. You can see here, everything we picked it up from the cast one by one and place it inside oral cavity. So everything should seat, even this part should seat properly, the back portion provided by the lab, which connects all your three single units of this impression copings. Okay. So now this is your, now we are doing the final prosthesis placement. So this is your transfer jig. Transfer jigs helps you to pick up your abutment from the cast and place it inside the oral cavity exactly like in the same position. Because when you're using a hex abutment, you can rotate it and place it in 6 directions. So while picking it up from the cast and place it inside the oral cavity, it should not rotate. Otherwise your process will not seat. So you have 6 abutments here. So if you have rotated even one, the process will not seat, and you will start scratching your head. It will become a nightmare because you will not come to know which abutment you have rotated. So transfer jig is very important. Okay, transfer jig is very important. So this is for the lower case. Again, lower case, we are doing a cement retained processes. Both type of processes, different types of implant placement also. Upper is a screw retained multi-unit abutment. You can see here. This is your metal trial, metal trial. This is your final processes. DMLS, PFM processes. This is the final smile of the patient. And this is a follow-up. 2 years follow-up. This is cement retained. Everything is seating perfectly. Okay. This is your screw retained. So now this is again one more case. If you can see here, okay, this was a patient this was a quite difficult patient because this patient was having OSMF. So his mouth opening was very much limited. Plus everything was highly compromised. If you can see here, actually we had done all in four. Along with that, we had placed two implants. With time, this implant had failed, but at least five survived. Okay. So here also, if you can see, we have placed multiple abutments. But if you look closely, this multi-unit abutment has not seated completely. So make sure after placing the multi-unit abutment, always take an IOPA. See, it is not seated properly. Later on, we do some amount of profiling of the bone, then it is able to seat. Okay. So make sure whenever you are placing the multi-unit abutment, take an IOPA to confirm they are seated properly. Otherwise, you will start doing work like this only and the processes will become loose with time because this has not seated properly. So keep that point in mind. So this is a patient, again a full mouth cases, multiple grossly decayed teeth. So we had to do full arch case for this patient. We have done this root submergence technique. It is called root submergence technique. We have placed multiple implants here. We have done tilting of this implant. We have placed multi-unit abutment, and these are all straight multi-unit abutments. Okay, you can see we have placed. So when you are doing a full arch case, thing is that always remember, try to place as many implants as possible within prosthetic reach, of course, within prosthetic reach, and so that you are considering the future complications also in your mind. Okay, so that if something happens in the future, one of the implant fails and all those things, so you have some kind of a safety net. Okay, so now we have placed at around 7 implants in this case. So when we did the prosthetic planning, so you can see this implant is too much palatally placed. So when we did the planning for the metal, so we found out that if we go ahead and plan the process will come around something like this. So one, the patient might have speech problems with the tongue. Secondly, there might be undercut leading to food lodgement. So we left this implant sleeping inside in the final processes. So you can see here, the technician has not considered this implant in the final processes. And sometimes if you want, you can to increase the passivity, you can split the processes also here because there is no cantilever. So I am fulfilling all my prosthetic principles also. There is no cantilever. Terminal abutments are used. So you can see this is the lower and this is the upper. We have done the split here to make it more passive. There is no cantilever in both the cases. This implant is left sleeping inside. This is 8 months follow up. Okay. This is the final smile of the patient. So now again this lower case, save natural teeth if it's possible. These teeth were salvageable. These all we had to remove. So we did again tilting of the implants and this is the final processes of the patient. This is the final smile of the patient. So this is now a case. We have done guided surgery for this case for the upper arch. Lower, there was some complication was there. We had placed one implant here, one more implant was placed here, but there was some amount of residual infection. So patient developed perimplantitis, so we had to reduce it. But luckily this patient was wearing a bridge, so that was taken consideration. We remade the bridge, so patient was comfortable with that. So this is how the planning is done for the guided surgery. This is the photo sent by the radiologist before he was doing the fabrication of the guide for the upper arch. This is the CBCT of that patient for the maxillary arch. Now this is the guide for the patient for the maxillary arch and these are the implants. This is the multi-unit abutment. This is lower. This is the PFM bridge. This is your Emax caps. This is your Emax tabletop. This is your monolithic zirconia screw retained on a tie base. This is their upper screw retained zirconia prosthesis. Okay. So with zirconia, you have to be very careful. If you, especially if you're doing full arch, make sure it is 100% passive, because zirconia is a very brittle material. It is least forgiving material. So if you do not get passivity, it will fracture. Some amount of elasticity still you can have in your DMLS, but not with zirconia. Plus, you have to have sufficient width between two abutments also. The connector size should also have sufficient width, otherwise it will fracture. So that you have to discuss with your technician. We have used the titanium cylinders. So this is the final smile of the patient, upper arch. One implant was extra, so we left sleeping inside, and this was tilted. This is 6 months follow-up. So this is low. In this case, this was straight. We have placed 3 axial implant, but you have done tilting here. You can see this is the sinus line which was coming. So we did not want to do sinus lift. We tilted this implant. This is again 16 mm. See, if you would have done sinus lift, you would have placed 10 mm length, but this is 16 mm, and you are engaging the opposing cortex also. So you are getting bicortical engagement. Okay. So, but again, you have to use, this is the lower implant level prosthesis, human retain. You have to use multi-unit abutment because you have done the tilting. It is 45 degree. You have to use multi-unit abutment to correct the angulation. So this is again screw retained DMLS PFM prosthesis. You can see this is the implant. This is a multi-unit abutment to correct the angulation, and this is your sinus lining. So you can place 16 mm implant, more BIC, and better torque also. So this is again case I did at consultation. So I do not have the digital photographs. So you can see this is the whole sinus lining. If you can appreciate, this is the whole sinus lining. So ideally it is a case of direct sinus lift. Ideally speaking, you need around 2 cc of bone, do some direct sinus lift, wait for 6 months, then place your implant, then wait for another 3-4 months, then do loading. Okay, so it will take around 1 year to finish this case. Now nobody wants to wait that much long. Trust me. So this is the tilting. I apologize for the bad quality of this photograph because this was photograph taken on the monitor. This eye case I did in consultation. So this implant is there. It has gone palatally. It looks like on IOP it is engaging this tooth. But if you can remember, the tooth when it goes apically, it comes out buccally. So I've gone palatally. And this is your pterygoid implant. Again, multi-unit abutment we have used. And this is the final process of the patient. There is no symptom in this. You can see that I have not done any kind of root canal treatment. This is again 16 mm, 16 mm. And this is your screw retained prosthesis. You can see we have made crown till 8. There was space available. So we gave the patient crown till 8 also. Okay. So this is a case, again full arch case, multi-unit abutment, lower jig trial. This is how the jig is sent from the lab. You pick it up from the cast, place it inside patient's oral cavity. If everything is seating properly, don't take any X-ray. Your life is simple. This is a BIS trial. You're checking for occlusion. BIS trial. This is your final prosthesis. Highly polished. Don't have to pick up any burr. Just pick it up and place it inside patient's oral cavity. This is your DMLS prosthesis. You can see screw retained and convex intaglio surface. That is very important. Convex intaglio surface, not concave, because it is not a denture. Denture is a removal process. Patient will remove it every night. Then he can clean the internal surface, which is like a concavity, like a bowl. So he can clean it. But this is a fixed process. You need some kind of a elevation, convexity, so that the food does not sit here. It flows away. So make sure you have a convex intaglio surface, not concave. Okay, both are screw retained, upper and lower. Both are screw retained. And this is the smile of the patient. Tilted, you can see we have done, this is your sinus lining, this is your sinus lining, this is your 5 mm diameter, 5 mm diameter, and why to tilt when you can place axial implants. I have not done any tilting here. Straight implants and multi-unit abutment. Okay, final smile of the patient. This case again was done at consultation. So ideally, this case was a case of full mouth rehabilitation. See, I told you before also, implantology is prosthetically driven, not surgically driven. So ideally, this case is of for full mouth rehabilitation. Means this patient requires raise of bite so that you can get sufficient amount of prosthetic space that will have a very good long-term prognosis. But as I told you, I did this case as consultation. So I'm not the boss of that clinic, but it is my duty as a doctor to make the other dentist and the patient understand everything, so that now the patient can understand the pros and cons. And still if he agrees that okay doc, I understand, but I want to go ahead with the smaller procedure, so then we can go ahead. Okay, I'm not telling to leave the case, or I'm not saying it is the ideal case, but we have to sometime think practically. But as a doctor, it's my duty to tell him. So that's what we did. We told the patient that ideally you require full mouth rehabilitation, because you can see with the OPG only you can make out it is like kind of in a situation of a collapse bite. Okay. But patient did not want to go through it. So you have done tilting of the implant. See, this sinus is here, this sinus is here. So we have done, this is again 13 mm, this is 16 mm implant, and lower we place straight implant. Multi-unit abutment in the upper side to correct the angulation. So this is 2 and this is 2. See, with multi-unit abutment, one thing is there, at least you require minimum 2 implants. You cannot do it on 1 implant. Now I know few companies have come up with a single unit multi-unit abutment also, which are hexed. But if you are using normal multi-unit abutment which are non-hexed, which has a non-hexed surface on the top of the prosthetic platform, minimum try to you minimum you have to give 2 implants. Better to give 3 implants. Better means if one more pterygoid would have been here, then it would have been a much better case, because then you have 3 implants. It is like a tripod. You can remember you have a stand for a selfie stick. It is like a tripod. If you have 3 stands, it becomes more stable. Okay, so with a tripod effect, it becomes more stable. So same applies here also. So whenever you're using multi-unit abutment, make sure minimum you have 2 implants, preferably 3 implants. Otherwise, you have problem of frequent screw loosening. That is the problem there. Okay. Lower again, we have this is the screw retained on a tie base. This one is SCRP, Semen retained, screw Semen retained processes. This is your normal screw retained PFM process. This is SCRP. This is screw retained on tie base, titanium base. Okay, this is also one. I think so. This is that complicated case. No, this is that normal. Okay, okay. So this is your open tray. You have taken the. You're going to take the impression. Okay, this is how you take the impression. This is your final processes. I do not have all the photographs of this case. So just to trying to show you, you have done tilting of the implants. This is kind of all in four, but because I was having space, I placed 2 short implants also. These are 16 mm, 16 mm. These are also 16 mm. These are I think so. These are again 18 mm, and these are 5 by 6.25, 5 by 6.25 short implants. Okay, so this is your again a compromise case. Patient had some financial issues. So in the lower, we went ahead with the mandibular overdenture, but on the maxilla, we did a tilting of the implants. Patient had knife edge ridge, so all implants were palatally placed. Okay, even if you have knife edge ridge in the maxilla region, and you went ahead with the palatal placement, and if you have some amount of thread exposure on the palatal aspect, don't worry, because your palatal fibrous tissue is very dense, it will never resorb. So again, you are safe with it. Okay, you don't have to graft on the palatal aspect. So we have placed 5 implants. Again, multi-unit abutment placed. This is your, we are planning for mandibular overdenture. So you can see I've done the palatal placement. You can see, you can appreciate that I've done the palatal placement. This is palatally placed, palatally placed, palatally placed. You will be able to appreciate it much better in the prosthesis. This is the final prosthesis, because the patient was a old lady with a severe bone loss. So as you can see here, there was lot of space available. So that means my interarch space will be very high. See, the type of prosthesis, I will just talk a little bit about it, because time is also coming up. So if type of processes is anatomically driven, it's not something like that you will tell, I will do only this kind of processes in all my implant cases. It is not possible because the type of processes is determined by the availability of your interarch space. For example, up to 8 to 12 you can do a cement retained processes. If it is less than 8 or 9 you can do a screw retained processes. If your per arch space is going beyond 15 space, you cannot do a single FP1 like kind of a single screw retained process. You have to go for a hybrid processes. Hybrid means it is composed of two kind of a material, like you have a bar kind of a thing, and over that some substructure is made. It can be either a DMLS bar, it can be a castable bar, metal bar, it can be a titanium bar, and over that you can have either a composite bridge or a zirconia teeth, something like that. It has to be a hybrid processes. So in this case, because the inter-arch space was very much high, so if you give a PFM processes, it will become very bulky, very heavy. You will have lot of processing errors because you will have porosities and all those things which we used to read in your casting defect section. So we went ahead and went with the hybrid processes. This is a DMLS bar and these are your composite teeth. You can use acrylic also. Acrylic is cheaper, but acrylic is less strong and it tends to get chipped off very easily. Even if you have sufficient space, it gets chipped off very easily. So composite is better. These are Breedent company composite, which is very good. So now you can appreciate the palatal placement. You can see all implants are, these are palatally placed. So this is the smile of the patient. This is your DMLS bar with the composite teeth. That is why they are looking, because they are made up of composite, they are looking radiolucent. Okay. This is a case. Again, tilting. You have tilted two implants. Plus I was getting space here. So we have placed two short implants also. And lower, neat and clean. Axial implants. Why to tilt? And this is your again screw retained prosthesis. You can see this is the final smile of the patient. Again, this case was done at consultation. So this is the photograph which I got. So you can see here, this is your upper is screw retained, lower is cement retained. Okay. Again, one more case. So this is a case, if you can see here, this we did on the upper left side. You can see there is 2-7. If you can see closely, there is hardly any bone left in 2-7. 2-6, there is no bone. There is no bone only at all. So again, this case, ideally, if you want to place axial implant, you have to first extract, wait for 2-3 months, then do direct sinus lift, then wait again. So we went ahead on the day of surgery, only one pterygoid implant, one palatonasal implant. See, this is the this is the lens still I'm using to engage the pterygoid plate, and you are placing the pterygoid implant. This is again 16 pterygoid implant. And no, sorry, palatonasal I did not do. I tilted my implant here. This is a sinus lining. I will go up till here and then place my implant. You can see this is a healing abutment. This is a pterygoid. This is a healing abutment. You have skipped your sinus completely. This is a normal implant, axial implant. Okay. So now this is your jig trial. Jig trial normally lab make it with pattern resin, but if they are able to make it with plaster of Paris, that is 100% accurate then. Because when you use a jig trial made up of pattern resin, again pattern resin will have some amount of flexibility. Like you have picked it up from the cast and you're placing it inside patient's oral cavity, and some discrepancies there, and if you press it, it will again seat because it has some plasticity. But with plaster of Paris, the problem is that even 1% discrepancy is there, it will develop a crack. So that is 100% best. If you can get your lab technician to make a jig trial made up of your uh, plaster of Paris. So this is again a mill titanium bar, anodized bar with composite teeth. Screw. This is now you can appreciate the intaglio surface. It is convex, elevated, not concavity. Okay. So this is your mill titanium anodized bar, and this is your composite teeth. This is your final prosthesis, screw retained. and this is your zirconia screw retained on a tie base. So again, one more case of tilted implantology. We have tilted this implant engaging the sinus lining, multi-unit abutment. This is again your milled titanium bar with a composite teeth because there was lot of crown height space. You can appreciate this is your tilted implant. On the right side also, this is this is your paralleling guide. We are engaging the pterygoid plate. This is your pterygoid implant. This is your normal straight axial implant. This is your palatonasal implant. Palatonasal implant engaging the palatal bone, going behind the sinus and engaging the nasal floor. And this is your final process because the crown height space was more. So again, this is your DMLS bar with the composite teeth. It is very light in weight and strong also. You can see three implants, again screw retained. Okay, you can appreciate the fit. Okay, this is the case. Again tilted, all in four. Space was available, so I was able to place one more short implant. But this is again 18 mm in length. These are 16 mm, 4.2 by 16 mm. This is your healing abutment. Okay, screw retained prosthesis, DMLS prosthesis. You can see 1, 2, 3, 4, 5 screw retained. This is the final OPG of the patient. Straight multi-unit abutment, angulated multi-unit abutment, and this is your screw retained DMLS prosthesis. This is an interesting case. If you look closely, we have to replace this 2.6 and 2.7. See, 2.7 you can see hardly any bone is there, nothing is there. Means how will you do sinus lift also? And 2.6 also is grossly decayed. No bone is there. So we went ahead with one pterygoid implant, one palatonasal implant. This is a palatonasal implant, this is a pterygoid implant. You can see palatonasal implant and pterygoid implant. And this is again your DMLS bar with composite teeth. You can see palatonasal, pterygoid, screw retained, composite teeth. This is our again case done at consultation, upper and lower arch screw retained on tilted implants. See, you can appreciate the tilt here. See, this is the sinus lining, so you have to tilt more. This is around, I think so, 50 to 55-degree tilt. This is again tilt engaging this lateral wall of the medial wall of the sinus lining. This is your engaging the nasal cortex. This is all in four. And I was getting some amount of bone here, so I was able to place one short implant also, 5 by 6.25. Okay. And in full mouth thing is that this is the study done by the Kalmish Institute also. What they found out was that if you're doing full mouth cases, you will get this one complaint from the patients. They are saying, Doc, I'm able to eat everything. I'm able to chew also everything. But problem is that I do not feel at home feeling. But it looks like I'm having something artificial. He's able to speak and all those things. That is okay. The reason for that is that because all these implants, all occlusion is fine still, but they do not have the property of proprioception. There is no nerve supply in it. Okay, so there is no connection through the brain. That is why if any stone particle also will come inside the teeth, patient will bite it because there is no proprioception. So if possible, and you are doing a full arch case, and if you can, and it is a healthy teeth, try to leave the posterior healthy teeth as it is. If two teeth are there, one in this arch, one in this arch, that is better because that will prevent the collapse of bite also. But again, if possible, leave one teeth also because this nerve supply will give him some amount of proprioception and some amount of at home feeling in the long run. Okay, this is my last case. I have a lot of cases, but I will finish here. This is my last case. With this case, I will also comment this. Do not try this at home. Okay, because this is something new, but I tried it and it worked. I read it through the articles. So this is kind of a tuberopterygoid implant, and this implant, if you can say, I think it is 25 mm in length. Okay, what happened is that I went in between the roots of the premolar and engaged the nasal cortex, lateral wall of the nasal cortex. If you can see here, okay, I did not do the RCT of this tooth. Patient is completely fine. I have a follow up also. Okay, so this is the multi-unit abutment, 45-degree. Okay, and multi-unit abutment in the posterior aspect. This is a screw retained DMLS prosthesis. So this is This is the sinus lining lateral wall, and you are engaging the nasal cortex lateral wall. This is your Ravan bridge. I did not do it. Somebody else did it long time back. Okay. So with this, I end my session. You are most welcome to connect with me on my Instagram and WhatsApp also. Okay. I have a lot of videos on my Instagram profile also. You can all watch them. And if you have any queries, please do ask me on WhatsApp also, Instagram also, and you can ask me here also. This is my hospital where I work. We were the first to start the implantology workshops in Gwalior in 2016. Since then, we have been conducting many workshops in my hospital. This is set up for microscopes, a small library we have made, my wife. So we do a lot of live surgeries also. So this is one of the batches. Lot many students we used to get from before this Taliban thing, Afghanistan. Lot of oral surgeons used to come. So hands-on along with live patients we do. This is again an Afghani doctor came for 10-15 days. We used to do a lot of surgeries in Bhopal also. He's one of my very good friends from Bhopal. We did it in Bangalore also. We did it in a college also. So you can see. So that is how I end my session. Thank you, everyone. And please ask as many queries as you can. Okay, so I'll start answer the queries one by one. Which implant system do you use? I use multiple systems. So it is not particularly which implant system you're using. I'm to do multiple systems. I'm not attached with any company. So I will not take any names here. You can use any system. It works. Means uh, driver means more than the car. I know Maruti will have differences with BMW, but still you can, whichever system you're using currently, I think nowadays every system has multi-unit abutments. So you don't have to change the system per se. If you're using any system right now, straight away you can go for tilted implantology. Only thing is that you have to see that how much angulated multi-unit abutments they have. Because if you're going for up till 45-degree, most of the companies have, but beyond 45-degree, very few companies have multi-unit abutment. So if you're tilting more beyond 45-degree, so then you have to think about some other companies like 50, if you're going for 60-degree also. So Norris has it, Bioline has it, now Adin also has it. So many other companies have it, but you can go ahead with your own systems. Have a look at the catalog. So that will help you. Are you doing digital impressions for implant? Yeah, I do both. Digital implants, or I do digital also and I do manual also. That is a personal choice. It does not make a difference in your processes. Okay, don't think digital is more accurate. No, studies have been done, both are accurate. So don't think digital is more accurate than your manual. It is not something like that. So don't worry about that. How to place palatal nasal implant, that is a little bit technique sensitive, but you can connect me on the WhatsApp because that is a separate discussion. So I'll send you some CBCT slices. You can have a look at it. So it is little bit tricky because you're not able to see that much properly, and you can go for guided. You can plan it with your radiologist. That will help you so that it helps you to understand it and makes the things easier for you. Thank you everyone. In case of multi-unit abutment, there is no contact till gingival margins. There is no contact with the till gingival margins with the prosthesis. Why can you explain? Is there a chance periimplantitis in poor oral hygiene? I'm not able to understand your question, but there's no contact. No, it is not something like that. You can, with the multi-unit abutment, you can go subgingival also. You can decrease your collar, right? It is not something like that with multi-unit abutment. You have to be supragingivally. No, no, yeah, no, it is not something like that. Okay. And the chance of perimplantitis, no, 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 chance of perimplantitis are very rare because your implant is very deep inside the bone. Above that, you have so much of soft tissue is there. You have a multi-unit abutment. Like this is your implant here. I'll just, just a second. I'll share this. Uh, uh, just a second. I will just a second. See, for example, I was telling about, I'll come to answer a question again. So this is around 55 to 60 degree, but this was a add-in implant. So add-in, they had only 45 degree. That is why if you can see in the prosthesis, in the final prosthesis, my screw hole was coming buccally. If I would have taken 60 degree, it would have come on the occlusal surface. So that is how it helps. Okay. And this multi-unit abutment, you can see this is the bone, this is your soft tissue, all around this is soft tissue, this is your prosthetic platform. So it is equigingival. It is easier to clean. Like same principle of crown-based dentistry. In crown-based dentistry, in the posterior region, what they say, keep your crown margin either equigingival, or Rosenstiel says you can keep it supragingival also because it is not the area of prosthetic concern. So it is easier for the patient to clean, easier for the for the patient to clean with the brushing and all those things. And you can always prescribe flosser. Flosser is a very good thing. And plus this will have a tissue attachment with the titanium. This is a polished collar. So it will have a uh, proper seal, proper soft tissue seal. Okay. So now multi-unit apartment question is done. Now what more question? Thanks, but can I? There is no ballet. No, bilateral symmetry of the implants is not that much, means in some cases because the bone is not available. So some cases we are not able to place a short implants here or there. See, if it is like an all in four you have done here. If I'm not able to get the bone here, that means I will not place, it does not signify that I will not place one more implant here. No, that is not the reason. If you can place one more implant here and you're not able to place here, so it is okay, not to worry. More implants is merrier, no, it is not going to harm you in any ways. Okay, so in an implantology, you understand this point is that the force distribution is equally distributed all over the implant. That is the beauty of doing a full arch implant. You get cross arch stabilization. So if patient is chewing from here, but the forces will be distribution up till here. So that is the best part about doing the implantology. Okay. Center also, if you can place, it is not that much. If you're not getting bone, you can place in the center also. Normally it is avoided, but if you're not getting bone, you can place in the center also. Okay. But normally you are right. It is not, if you can, better to avoid it. Parietal nasal, I told you, kindly connect me on the WhatsApp. Okay. So that then it is much better because it requires deeper discussion and better. I told you, if you want to start with it, do a CBCT and get a guide made. That is much better, much easier also, so that you can really understand the planning for the palatonasal implant. But make sure if you're doing a palatonasal implant, lot of controversy is there. Nowadays, people, what they're doing is, I do not advocate that. Okay, that is my personal view because there's no long-term follow-up. If you're doing a palatal nasal implant, please don't do single palatal nasal implant and place a normal cement-retained implant. Because when you see, if you are tilting your implant, if you are placing or tilting your implant, and it is single, it is not joined to other implant, then they all the concepts of mesh will apply. You have placed the tilted implant, so it is as per mesh. You have not done it intentionally. It is a mistake. So now you have all the tangential forces will be applied on your abutment, and you will have crestal bone loss. But when this tilted implant is joined with another tilted implant, so you have equal force distribution. Okay, so then the things changes. Okay, so don't do that. Ki I will place only one single tilted implant. It is long and all those things. So long term, you will have a complication, crystal bone loss. Don't do that. To use 30-degree abutments, how much implant can be angulated? No, you are asking me in a reverse reverse way. Angle of the multi-unit abutment is decided based on the angulation of your implant. If your implant is 30-degree tilted, you have to use a 30-degree multi-unit abutment. You cannot go reverse. That in my armamentarium, I have a 30-degree multi-unit abutment, so I will tilt my implant 30-degree only. No, you have to go as much distally as possible, as much close as possible to the sinus lining. Like this is your sinus lining. You have to go as much distally as possible because you want to spread your AP spread, anterior posterior spread, so that you have minimum amount of cantilever. See, all in 4 was introduced by Paulo Molo for this reason only, to increase your AP spread, decrease the cantilever, and to skip bilateral sinus lift. Okay, so based on an implant placement, you will choose your multi-unit abutment. Don't do it in a reverse order. When can we go for cement retained prosthesis or screw retained prosthesis? No, that depends. See, screw retained or cement retained, if you're doing full arch cases, preferably it is always preferred to do a screw retained prosthesis. If you want my answer in one line, because so that you have an option of retrievability. I've shown you cases with cement retained. Many people are doing it also. They have a long-term follow-up also. I also have a long-term follow-up of 10 years, 15 years. But I'm talking about the preference. If you can go, then do screw retained processes if you are doing a full arch cases. Because then retrievability is an easier job. You can always repair the prosthesis, which is very easier. And obviously maintaining hygiene is very easy. Patient comes to you after 2 to 3 years. You can remove everything, clean everything, see any ifs and buts, and you can place it back. So that makes life easier for you also and for the patient also. Okay. What type of implants you use for length of 20 mm above, like they are basal with rough coating? No, these are not basal. No, no, no. None of these implants are basal. They might be looking like a basal implant, but they are not basal implants. Okay. These long implants companies, what they do is now, especially for the pterygoid implant and for these tilted implantology, long implants, what they do is they make their apex very sharp. Okay, reason of doing is that they want their implant to engage the bone as easily as possible, because see, if you're doing a knife edge ridge and if you drill 3 4 times, with the drill only you will destroy your bone. Okay, so that's why they're making your implant, apex of the implant very sharp, so that even after 1 or 2 drill only, your implant will engage the bone, and while going inside the bone, your implant will kind of expand the bone, which will lead to densification, like you read your denser bursts, and hence will give you more torque, and you can do immediate loading also. So that is why these companies are making implants with a sharp apex, but uh, these are not your basal implant, that is for sure. Just what time plan for no, one implant multi-unit abutment with single implant is sufficient. What implant system is there? You can search like in add-in also they have. In add-in they have. I think they have in Strawman also, where you can use a multi-unit abutment, single multi-unit abutment on a single tooth. Okay, they have that kind of a thing. Book you want on basics of tilted implantology, you can WhatsApp me. I'll let you know. Okay. If possible, I'll send you the on the soft copy also. Can we use both multi-unit abutment and straight implant? Means straight implant, you're trying to say straight multi-unit abutment. If you're saying angulated multi-unit abutment and straight multi-unit abutment, of course you have to use them, because two are straight, two are tilted, so you have to use them. If you're asking me whether I can use multi-unit abutment for the tilted implant and straight normal cement retained abutment, you can do that. You can do that. You can again do that, but normally it is not advisable. It is normally advisable that for one full arch, use same type of abutments. If you are doing cement retained, do it full arch cement retained. If you are using multi-unit abutment, do full arch multi-unit abutment, whether straight or tilted. But like you said, you can do it. In one of my cases also, if you look closely, in the two anterior implants, I had used the cement retained abutment because I did not have the availability of the straight multi-unit abutment. to be very frank with you. Can you explain how to choose the prosthetic material like DMLS, titanium, composite, other cost factor? Yeah, cost factor is a major issue, of course. And based on the prosthetic material like DMLS is a kind of a process you can do for FP1, FP2, FP3. You can do DMLS, which is again a PFM processes. Sorry, PFM processes, but you can do it up to 20, 12 to 13 of per arch space. So space analysis, how can you can do? Ideally, you have to do it pre-surgically. Pre-surgically, do a diagnostic mounting, get a denture made in the clear acrylic, and then you can analyze your speech and everything, phonetics, and you can analyze your jaw space, interarch space. Okay, that you can do. That is the ideal way of doing it. Otherwise, with time, what happens is that when you look at the patient, like I showed one of your patient in which there was a lot of bone desorption was there, and I can see by looking at the patient that he will have a lot of interarch space. So from day one of doing the surgery only, I had in mind that I have to go for hybrid prosthesis. Okay. Otherwise, what happens is that when you're doing the jaw relation during after osseointegration and after doing the jaw relation, you have sent the cast to your lab technician. Lab technician will mount it on the articulator. Then you can have a technician discussion with your technician, and he will guide you. Sir, per arch space is there, and now we can choose so and so material. Because if it is more than 15 then you have to go for hybrid processes. Like I told you, some kind of a bar based processor. You can go for a castable bar DMLS bar. If you're doing a scanning, you have to go for a DMLS or above that. You cannot go for a castable bar, or you can go for a titanium bar, but of course it becomes very costly. Because I can show you one case. Now the session is over, but I've done one case of mill titanium full arch. Per arch is cost me around, I think so, 70 to 80,000. So that is how it goes. And composite, on again framework you have decided. Then on top of that also you can decide. You can go for a zirconia also. You can go for a composite also. If you want something lighter and little bit on the economical side, you can go for composite. Okay, that is how it goes. So that also depends on cost factor. That you have to discuss with your lab. That is why when you're doing implantology, what I advise is which I also did it. So which was kind of a blessing in disguise for me is that always start your, if you are starting your implantology, then my advice is that always start with good labs. That will make your life much easier, because lot of these things which I showed you will be available to you by the lab itself, like transfer jig trial. Most of these local labs, they do not know what it is. And if you tell them to make it, they make it very in a very pathetic manner. So that is how it goes. Convex intaglio surface. Lot of these labs does not understand what is concave intaglio surface. They will keep on making those old ridge lab pontics. And all these type of process which I am telling you, it will be done from a lab which is a standard lab, because these are all costly products. So they also understand the technical aspect of these zirconia, composite, mill titanium. They themselves understand this much art space will require this type of processes. Means sometimes I have a discussion with my technician. I am discussing with him that I am planning for this type of process. Then he also comments, sir, this space is less. I think we should go for this type of processes. You can get that point, but that is only possible if he is also technically sound. How much degree variation between multi-unit abutment is allowed so that prosthesis can seat is passively? How much degree variation? No, your processes can seat passively. Multi-unit abutment variation, it will seat properly because these are all are non-X. These are all non-X. The prosthetic surface is non-X, and you have to make them as much parallel as possible, because the driver, the screw which is which with the help of which you place your multi-unit abutment, when it comes out in the oral cavity, like four implants is there, so you are looking at the case from the front to make sure that all these screw channels, the screw holders, are parallel to each other. As much parallel they are, it is easier. If one of these screw holder is slightly little bit tilted also, still they will seat. If they are like this only, that means you have chosen a wrong multi-unit apartment. Like you have chosen 30°, but the case requires 45°. So that means you have chosen a wrong, uh, wrong multi-unit apartment. Okay. In case of In case of nasopalatal and pterygoid implant, what are the chances of injuring the greater palatine nerve? Injury causing of more amyloid. Greater palatine nerve, there are very rare chances. If you go too much medially, then only you can go. Otherwise, it is very safe procedure. No, hardly any chance. It is very rare. I've not seen anyone doing that. But I have discussions with so many dentists and all those things. It is very rare because so much palatally you will not go. It is not like you are going 50 or 60 degree. So it is very rare. Don't worry about that. If we tilt implants more than 45 degree, but multi-unit is available only till 45 degree, how do we do the process? Still you can do. No worries about that. That's why I told you choose a system which has more degree of multi-unit abutment. But still, I showed you one of the case in which the implant was like 55 to 60 degree. I used 45 degree multi-unit abutment and it was going like this. So my excess hole finally came out buccally. But still, I was able to make my processes and everything seat passively. You can still do it. Don't worry. But it cannot be like a difference of around 25 degree. Means it requires 60 degree and you have placed the multi-unit button on 30 degree. That much variation will be difficult for the process to accommodate. Can you explain again how to bypass mental nerve move? Sorry. Can you explain again how to bypass mental nerve loop and tilt the implant? See, if this is your supposedly this is your mental foramen, so you know that anteriorly it forms a loop of around 5 mm. Okay, anterior it forms a loop of around 5 mm. Okay, so if you're tilting your implant, make sure this gap between the distal aspect of your implant and this mesial aspect of your implant and distal aspect of mental foramen should be 5 mm. 2 mm is for safety. So expose your mental nerve, look at it, then you can make a marking with the help of a with the help of a this marker pencil are there, surgical marking pencil. You can make a marking over it. Okay, and then you can draw one line from here till here till the crest of the bone. So that is your angulation. Okay, get my point? This is a mental foramen. This is a mesial aspect of the distal mesial aspect of a mental foramen. After 5 mm, make a mark here, make a mark here, draw one straight line also, and draw one tilted line also. So our implant will start here. Okay, the boundary of your implant should touch the line. Okay, that is how it is done. If you are starting your case for initial cases, you can do it like then. Edentulous patient with financial issues, sir, how to manage? Should we do overdenture or all in four? See, one misconception is there among the patients also that less number of implants will cost me less. That is that is not how it should be done because less number of implants, but you are giving the same number of teeth. So lab cost will not differ. Plus, you are using good quality implants. These tilted implants, you have to use good quality implants. You are using multi-unit abutments also, which are costlier. So, cost-wise, it does not save any money. So, we should not have that misconception among ourselves also and make it among the patients also. That less number of implants means uh, less cost to the patient. Whenever you're doing a full arch, it is better to give a package to the patient and talk more about the processes. Because see, understand, the implant is Tom, Dick, and Harry for the patient. Patient does not know about the implants that much. Okay. Uh, okay, they are getting a lot of information from the social media, all in four and all those things, but they do not know in the detail. What they want is a good quality teeth. So talk about the teeth. Okay. Focus more on the processes rather than talking about the surgery. So when I discuss a case with the patient, I tell him a package. Okay, I tell him a package that single arch I will charge you this much for this type of processes, irrespective of the number of implants. Whether I do one implant, whether I do 8 implants, that is my headache. Okay, so I do a surgery with a free mind. I don't have to worry at all because I am not quoted to the patient on the basis of the number of implants. So, if budget is an issue, obviously overdenture will cost you less. Obviously, overdenture will cost you less. In the lower, if you, minimum you can do with 2 implants, ball and socket, it hardly cost you anything. You can get the denture made from the local lab, 2 implants, ball and socket, pick it up, and you can give a overdenture. In comparison to that, all in four, along with the prosthesis cost from the lab, obviously it will cost more, all in four. In full arch care for cement retain prosthesis, which abutment should be used? For cement process, you have to use normal implant level abutments, which any companies gives you. Normal cement retained, you have straight with different collar heights and which have angulation also 15 degree, 20 degree that you can use normal. If we want to do delayed loading for full mouth cases, should we place multi-unit abutment during surgery or after osseointegration? Both you can do. Both you can do. But if you are placing it during surgery, so those multi-unit abutment will have some amount of force application from the tissue. When the patient will eat, some amount of force will be applied by the tissue because of the movement during the food chewing process and from the tongue also. So make sure your implant do have a good torque. Otherwise, they might fail because your implants are tilted. See, understand this point. Individually, these tilted implants are very weak. Together, when they are joined with the prosthesis with the help of cross arch stabilization, then they become strong. Otherwise, individually they are weak. So now you have placed individual multi-unit abutments, torque is less, patient is eating something, he will keep on eating, and tongue will apply forces. So because of the forces, if your torque is less, this implant might fail during the healing phase. So keep that point in mind. Secondly, of course, you can place it after osseointegration. That 100% you are right about that. But one point to be clear: whether you're placing it during surgery or after osseointegration, choose the angle of the multi-unit abutment on the day of surgery. Choose the angle of the multi-unit abutment on the day of surgery, whether you want to place it on the day one or after osseointegration. What happens is that you have placed your implants, tilted your implants. Now your multi-unit abutment you have chosen is for 45 degree, but still your multi-unit abutment also has a hex. So it can again seat in 6 directions. So sometimes what happens, you have placed the 45-degree multi-unit abutment, still it is coming out little bit like this. So what you do, you turn your implant little bit more clockwise, then it comes like this. So that can be done only on the day of surgery, because now if it is it is osseointegrated, you cannot turn your implant in spite of using the right degree of multi-unit abutment. So what you can do it, if you're placing a multi-unit abutment on day one, perfectly fine, no worries. If your torque is good. If you're planning to place it on the day after osseointegration, so what you do, select your multi-unit abutments on the day of surgery. Select the angulation. If you want to turn your implant, do everything. Check the parallelism. Then what you can do, take out them and make one sachet for them, one packet. Put the patient's name and write the implant. Like this is for 1/6, this is for 1/1, so that after 3 months you remember. Otherwise, you will get confused that this degree of multi-unit abutment I had used this side or that side. You will keep on trying it on everything. So that also you can do. But you have to try it on the day of surgery. That is very important. How much torque is advised for the multi-unit abutments? Again, follow the company protocol. For all these prosthetic parts, follow the company protocol which is given in your catalog. One of the common mistakes that we all do is that we never read the catalog. We listen to the dealers and all those things what they're saying is. So you have to read the catalog. How much torque is there? Normally for multi-unit abutment, the torque is around 20 to 25 NCM. But again, read your catalog. That is very important. What your company specifies, go up till that, not beyond that. Otherwise, you can yourself break the screw. How to consult the patient, educate the patient, and then quoting the price, getting the patient say yes to our treatment. How do we focus on patient saying yes to our treatment plan? To to let the patient convert to your processes, first you have to be confident. That is very important because patient nowadays can judge your confidence. If you're not confident in your treatment planning, then patient will never turn up. Okay, so first you have to be very perfectly confident. That is why I insisted treatment planning is very important in implantology, especially if you're doing full march cases. From day one you should know that will be my prosthesis in the future. Okay, so from day one, prosthetic planning should be perfectly fine. If your treatment planning is very good, okay, you can discuss it with among your seniors and everybody and your radiologist and all those things. There's no harm in having a healthy discussion. Make a treatment plan, and if you're confident, your patient will be confident. Okay, if you're not confident, then the patient can judge it from your facial features that what doctor himself is saying he's not confident. He will not say it, but he understands it. Nowadays, patients are very smart. So they are very much highly smart, and with all the information available at their fingertips, they know everything. That is how it goes. Plus, you can show them lot of videos, pictures, before and after. Only before and after, not the surgical photographs. Don't show them. Nobody wants to see the blood because for them implants are screws. So don't show the screws, blood, and all those things. A lot of people show videos drilling and all those. No, no. Just show them before after, before after. This is on day one. This is our last day. That's it. And don't use the terms like drills, taka lagna. I'm sorry, I'm using some of the Hindi terms if everybody is comfortable with that. Taka lagna, drill karenge, ched karenge, and all those things. No, don't talk about the surgery in detail and use technical terms like all the medical people do. They always use the technical terms: knee replacement, knee implants, heart transplant, stent, okay, and all those things. Okay, they never use the word like filter in the implants in the heart. They will not say कि छलनी लगानी है, something like that. What should be the approximate cost of the package we quote a patient for full mouth case? Again, depends upon the type of prosthesis, doc, which you are doing. I told you, depend upon the type of prosthesis and how much your lab is charging. Supposedly, if you are giving a DM, and obviously which implant system you are using, because that you have to calculate the cost of the surgical cost, implants plus multi-unit abutment, then the prosthesis cost from the lab, and then your profit sharing. Of course, your profit sharing should be more than the 50%. That is again a financial aspect, but it should be like a, if you are investing 1 lakh, at least you should quote 2 lakh. Minimum. Minimum it should be. So that is how the quotation will change, but not on the number of implants. Make sure, not on the number of implants. Okay. Means it should be in your mind, but the patient should not get that picture that my number, because I'm see for 6 implants, I means I'm in total I'm doing 12 implants, so it is 4 lakhs. But if I do 10 lakhs, then it is 3.5 lakhs. No, it is not like that. Whether I do 4 implants above, 4 implants here, all in four, all in four above, all in four lower, 8 implants, it is 4 lakhs. 6 implants above, 6 implants lower, again 4 lakhs only. Okay. So make sure your package is fixed. You do not change your package based on the number of implants. So you have to consider these two costs in mind first. Okay. You can WhatsApp me. We can have a private discussion because this is again a practice management point. For delayed loading in full mouth cases, what we can give as interim prosthesis? Can we give conventional denture till we give permanent process? Yeah, you can give interim processes. You can give on the, if you have done bicortical engagement and you have got good torque, you can give a interim prosthesis, whatever you want. You can give a PMMA prosthesis. You can give a hybrid prosthesis with acrylic also. Acrylic is nowadays not preferred because it is very poor quality material, but again, you can use it. Okay. With a bar with a hybrid kind of a process, because if you want something lighter and which is shock absorbing also, and if some occlusal discrepancy is there, so the material will chip off, but it will not transfer the load on the implants. You have to go for something lighter. So PMMA also you can give. PMMA, bar based acrylic you can give. You can use a conventional denture also. You can convert your conventional denture also with the help of titanium cylinders, and you can use them also as a temporary prosthesis. But that conversion technique, the conventional denture, because it does not have any metal substructure, it tends to break. That is one of the disadvantage. Otherwise you can use that also. And if you are saying that you want to use a conventional denture like a removal prosthesis, means as a temporary prosthesis, you are not giving any fixed prosthesis, you want to give a normal denture also, you can do that also. No worries, but keep it in mind, this denture will move your soft tissue, and this soft tissue will keep on moving your multi-unit abutment also. If you have placed your multi-unit abutment or your cover screw, if you are keeping your implant inside the bone, so so they also have some amount of pressure. So still you can use them, no harm in using them, but make sure if it is possible you reline them with a soft tissue conditioner. Okay, so it has kind of a spongy effect. It has like a soft tissue liners we have for denture. We used to read in our BDS times. So that you can use. Tell your lab guy to use a soft tissue conditioner so that it has kind of a spongy effect. So it will not apply that much of pressure. It acts like a cushion. So it will not apply a lot of pressure on the tissues. So that also you can use. No harm. I think I've answered all the questions. So if you have any more queries, you can always WhatsApp me or you can Instagram me. No worries.
Um, Thank you so much, Doctor. Thank you so much for sharing your valuable knowledge and expertise on tilted implantology. The concept, clinical insights, and practical tips he discussed today will surely serve as excellent take home points for all of us and help us improve our implant practice.
Yeah.
Thanks to you, all
Thank you
the
so much.
doctors for yeah. Thanks to you, all the doctors for sharing your
Thank you, everyone. Thank you so much.
yeah, patient listening and active participation throughout the session. I hope each one of you leaves this webinar with enhanced confidence and clarity.
Thank you so much.
Once again, thank you so much, Doctor, for your wonderful and informative session. We truly appreciate the time and effort you have dedicated to the Learn from our Master series.
Thank you.
Doctors, please do check out and follow Dr. Rohit Agrawal sir's Instagram page to appreciate his clinical work. To know more about upcoming webinars and workshops, please visit our website www.iadp.org and follow us on Instagram and Facebook pages. If you have missed any of our previous webinars, do check out our YouTube channel, and we would really appreciate if you could subscribe as well. Thank you all once again. Have a great night. Good
Thank
night.
you. Good night, everybody.
Good night.
Yeah.